So catecholamine synthesis. How catecholamine synthesize? First substrate is phenylalanine. We use this phenylalanine and giving a B4 vitamin and hydroxylase it. So when we hydroxylate phenylalanine, it can get converted into tyrosine. Again, we use this tyrosine B4 hydroxylase enzyme, and now we have phenylalanine dihydroxylase, so which is also known as dihydroxylase phenylalanine, known as DOPA. This DOPA is decarboxylase. We're using B6 carbon dioxide carboxylase enzyme and decarboxylase enzyme. We remove the carbon dioxide to make it dopamine. This dopamine using vitamin C and again hydroxylase. So we have hydroxylase, hydroxylation, decarboxylation, again hydroxylation. So triple hydroxylation of the phenylalanine to make it norepinephrine. So this norepinephrine using SAM, S-adenyl methionine and phenylalanine N-methyl transferase enzyme to make epinephrine. Epinephrine and also this norepinephrine, both norepinephrine and epinephrine, both use COMT, catecholamine O-methyl transferase enzyme, and make metanephrines, which are the metabolite. If these metanephrine is related to norepinephrine, these are normetanephrines. If it is epinephrine, these are simply metanephrines. These metanephrines are converted by MAO enzyme, monoamine oxidase, to make VMA, vanillyl mandelic acid or something related to that. So these are important in psychiatry related abnormalities. So the main catecholamine synthesis pathway is related over here. So phenylalanine using B4 and hydroxylase enzyme to make tyrosine. Tyrosine again uses that enzyme to make dihydroxyphenylalanine, known as DOPA. DOPA decarboxylase by using B6 enzyme to make dopamine, and this dopamine again B4 hydroxylase using norepinephrine. This norepinephrine is get converted by using a methyl transferase, simply said the methyl transferase, and make epinephrine. Epinephrine and norepinephrine using COMT or methyl transferase to make metanephrines, and which are MAO conversion into VMA. So the transferase, this norepinephrine transferase, is stimulated by cortisol. Cortisol stimulate SAM or phenyl N-methyl transferase, phenylalanine N-methyl transferase to make epinephrine. There is increased level of epinephrine in the body. This tyrosine over here, we have another shift. This tyrosine is converted into homogenistic acid. This homogenistic acid, it gets oxidase or oxidize to make this methyl acetoacetate, acyl acetoacetate acetoacetic acid, and it is converted into fumarate and used in the TCA cycle. So this is whole the diagram of the catecholamine synthesis. The next one is, now we are going to discuss the problems which are very much important in their different regarding these pathway. So if we have no phenylalanine hydroxylase, or we have a B4 deficiency, or we have no B4 enzyme, or also known as, which is known as just simply vitamin deficiency or enzyme deficiency, then we cannot make tyrosine. So there is increased level of phenylalanine, or which converts into ketone bodies. So so we cannot make, so no tyrosine, no melanin, no tyrosine, no dopamine, no melanin, no serotonin. So these all leads to no serotonin. So these all problems leads into PKU, or phenylketonuria. So there is excess amount of phenylalanine which is converted into ketone bodies. If there is no tyrosine, no melanin, then it is hypopigmentation. If there is no serotonin, there is CNS problems, abnormalities, or behavior problems. If there is no melanin, there is no tyrosine, there is also no T3 or T4 or no thyroxine, there is thyroid problem, hypothyroidism, thyroid problem. So the skin is hypopigmented, skin is eczematous, there is cerebral sears, cerebral abnormality, there is sears, and these sears are known as the refractory sears. Also there is a microcephaly. So this is the phenylketonuria. We have increased level of phenylketones in the urine. So phenylketones in the urine, no phenylalanine hydroxylase, no B4 enzyme, which is also known as malignant PKU, and we cannot make tyrosine, we cannot make melanin, which leads to skin hyperpigmentation, we cannot make serotonin, which can causes CNS abnormalities known as microcephaly or refractory sears. We have no thyroxine, hypothyroidism. So it all causes phenylketonuria. So the most important code word for this phenylketonuria is the musty body odor. So whenever we see musty, we always go for phenylketonuria. But over there we have a trick, that if there is a B4, either it is a B4 deficiency or it is a phenylketone amino acid problem. So the treatment is just to avoid amino acid phenylketonuria, also restrict amino acid, and also avoid using or restrict or avoid using artificial sugar known as aspartame, which has also phenylalanine amino acid. The next problem is, if we have homogenetic acid oxidase. So if we have no homogenetic acid oxidase enzyme, then we make up a condition known as Alkaptonuria, or also known as the Biochemistry. Why Biochemistry? Because no oxidation of homogenetic acid, we cannot make its So there is no methyl acetic acid, no fumarate. So no fumarate means no TCA. We cannot use TCA cycle. So there is increased level of tyrosine or there is increased level of homogenistic acid, and it present into the connective tissue. For example, it goes into the skin, it goes into the cartilage, it goes into the ear pinna. So if it is goes into the ear, it can causes a black ear appearances. It goes into the cartilage, it causing debilitating or worsen arthralgia. It goes into the skin, it causes the blackish coloration of the skin. And Alkaptonuria is especially important when the urine is overnight. If a baby is urinate in the washroom, and he forgot to flush, and in the morning the mother sees that the urine turns into a black, then it is known as the Alkaptonuria or BLK, Biochemistry. The Alkaptonuria, there is urine abnormality. So also we have albinism. So if there is a tyrosinase deficiency, there is no tyrosinase, we cannot convert tyrosine into melanin, then there is albinism condition, that is pretty much low yield. So next problem is homogenistic acid, homocystinuria, Cystinuria. Homocystinuria means we have the increased level of homocysteine. So how this homocysteine it gets into the body? So we have 4 kinds of problems. The first one is first I describe that how homocysteine is formed and how homocysteine is used in the body. So methionine, we have methionine. It uses methionine synthase enzyme and also methyl B12, and it gets converted into homocysteine. This homocysteine using B6 vitamin and also using a synthase enzyme. What synthase? It is synthesizing cystathionine. This cystathionine you again using B6 and make cysteine. We have also add up of the serine, homocysteine plus serine to make cystathionine. So overall we have folate and B12. So folate and B12, it gives methyl B12, and which used by the synthase homocysteine synthase enzyme using the methionine to convert into homocysteine. Homocysteine using serine, B6 and synthase enzyme to make cystathione. Cystathione using B6 to form cysteine. So now we have some conditions in which there is abnormality. So if there is the most common overall the most common cause of homocystinuria, if we don't have cysteine synthase, cystathione synthase. So no cystathione synthase enzyme. If there is no enzyme, so we cannot make this pathway. So all the homocysteine There is a increased level of methionine and homocysteine. Methionine is converted in homocysteine, so there is increased level of homocysteine. This homocysteine can cause homocystinuria. So how to treat this? We just give these products: cysteine, B6, B12 and folate. Why B12 and folate? Because B12 and folate, these all are converted, all are used up to make homocysteine. So we have a diversion. Physiologically, this pathway goes where methionine converted into homocysteine using these metabolites, homocysteine readily converted into cysteine and used in the body. So if this pathway is blocked, then all the methionine in the body is formed, it is forming homocysteine. So there is in order to treat, we increase the level of B6. Obviously, we give cysteine amino acid, we give B12 and folic acid. The next one is, if we have this is the overall most common. The most common genetic cause is if we have no methyl tetrahydrofolate reductase deficiency. So if we have no methyl tetrahydrofolate deficiency, we cannot make B6 and we cannot make folate. So if there is no folate, then we cannot make homocysteine. So how to treat this? We just give folate substrate in order to treat this problem. The next one is, if we have no methionine synthase. So homocystinuria, it is either converted into cystathione or either it is converted into methionine. So if we block this, either we block this pathway or we block this pathway. So the most common genetic cause is, if we have no methionine reductase, we cannot make the methionine amino acid. So there is increased level of homocysteine. So we just give folate and vitamin in order to make in order to lower these enzyme, lower this homocysteine in the body. So if we have the no methionine synthase or no methionine transferase, so if we have deficiency over here, so no methionine synthase, so there is increased level of homocystinuria. So just give methionine in order to sort out this homocystinuria. And the last one is, if we have the no affinity of whom? Affinity, if there is loss of affinity for this cysteine cystathione synthase enzyme to the B6, if there is loss of affinity for this B6 and cystathione, then it can lead to blockage of this pathway, increased level of homocysteine. So how to treat? We just give B6 and cysteine. Again, I will describe it by simply again review this. Homocysteine is either converted into methionine or either it converted into cysteine. When we have to convert homocysteine into methionine, we use a synthase enzyme, methionine synthase, and also we use methyl B12, which comes from folate and B12 or methyl tetrahydrofolate reductase to make methionine. If this pathway is saturated, then homocysteine is converted into cysteine pathway, or if we don't need methionine, we can just add cysteine, homocysteine plus serine, and using B6 and cystathione synthase enzyme to make cystathione, which use B6 to form cysteine. So now we have the problems, 4 type of problem, in which first, if there is a cysteine synthase enzyme deficiency, if there is B6 deficiency, if there is methyl folate reductase deficiency, or if there is decreased affinity of B6, and the most common is no cysteine synthase enzyme. The most common genetic is no methyl tetrahydrofolate reductase. So what happens when there is increased level of homocysteine in the body? Obviously, H for homocysteine, so we have increased level of homocysteine in the urine or in the blood, so homocystinuria. Then we have O for osteoporosis, bone abnormality. We have the morphin, M for morphin habitus. And then again O for there is a ocular problem in which the eyes are down and in, which is exactly opposite to Marfan syndrome in which the eyes are up and out. The next one is C for this is the clinical vignette in which the question arises. There is a serious abnormality which can lead to stroke, which can lead to TIA, which can lead to myocardial infection, myocardial infarction, which is also a thrombotic or also a atherosclerotic event. Also, there is a kyphosis and other insignificant symptoms. So the serious abnormalities and the eye are very much important in order to distinguish homocystinuria. The next one is if we haven't any alpha keto dehydrogenase enzyme, or if we have no B1 alpha keto dehydrogenase using thiamine. So if we have no thiamine, then we cannot use branch chain amino acid which are valine, isoleucine and leucine. So we cannot degrade and use it in the body. So there is increased ketoacidemia, and this ketoacidemia is neurotoxic and it can lead to the formation of burnt sugar or maple syrup urine disease. So how to treat? Just restrict the BCA amino acid and give B1 thiamine. The next problem is the most important is organic acidemia. So organic acidemia, we have two conditions. If we have no absence of B7 carboxylase enzyme which converts propionyl carbox OA. So if we haven't any propionyl CoA B7 carboxylase enzyme, or its next version is, or opposite version is, if we don't have methyl, if we haven't have B12, or we don't have mutase enzyme which is methylmalonyl double M methylmalonyl CoA, then we cannot, so this is a common, we cannot use gluconeogenesis, we cannot use urea cycle. So there is, we cannot use gluconeogenesis, we cannot use urea cycle. No methylmalonyl acid, no urea cycle, obviously there is increased level of ammonia. Which can, this ammonia can cause a high A9 gap metabolic acidosis causing sears. And if propionyl carbon, there is no gluconeogenesis, so there is fasting, hypoglycemia, we have the ketoacidosis, and we have the hepatomegaly. So how to treat this? We just restrict no, VOMIT, T for threonine, I for isoleucine, M for methionine, O for odd chain fatty acid, and V for valine. So this is organic acidemia. The next one is a little bit MCQ type 1 or 2 MCQs. So there is no amino acid transporters Where? In the renal PCT or in the GIT. So there is no reabsorption, so there is increased amino acid urea, which is cystinuria, and which leads to recurrent kidney stones. Kidney stones. And these stones, these amino acids are cola. A for arginine, L for lysine, O for ornithine, and C for cysteine. So cystinuria. So how to diagnose it? We just give a urine, sodium cyanide, nitroproside, which is important. Also we can use proton nuclear magnetic resonance spectrometry. And how to treat this? We just hydrate the patient. We give penicillamine. We alkalinize the urine by giving sodium citrate and acetozolamide, and also the important one, no methionine amino acid. So if this is all about the amino acid version lecture over amino acid. We have discussed all the catecholamines and all the protein related amino acid related problems.